Our next case is a 63-year-old male patient. He is a type 2 diabetic, hypertensive, having dyslipidemia, with history of old anterior wall myocardial infarction, having LV ejection fraction of 25%. His angiography has been done, which showed triple vessel disease, mid LED showing around 90% stenotic lesion, and it is a calcific lesion. OM showing around 70% stenosis, and mid RCA again showing around 60-70% stenosis. So our plan is to do angioplasty of LED lesion using robotic technology and plus minus rota ablation. Thank you. Now we are going live.
All right, can you guys hear us? Not hooked up yet. We need a few minutes to get our cameras hooked up.
Yes, sir. Your mic on, sir. You're on live.
Hello, can you guys hear us? Tell me when we're on.
Yes, sir. You're on, sir.
Oh, you can hear us. Great. Well, welcome to the other lab. We've been awaiting your arrival. I think you can see on the screen the LAD lesion that we're going to approach today. We've had a lot of discussions about how to approach this. Initially, the thought was roto-stenting. I think we're going to take away from the lessons this morning and do some imaging before we decide on whether or not to rotablate. And I decided I wanted to do this case like I would do this case at home. And that might involve an extra step or two, but it's to try to be a robotics first program. And to do that, what I hope to do is to wire and pre-dilate this lesion, followed by OCT. And so we'll show you the workflow of doing a combined sort of hybrid procedure. To do these things with devices that don't work in the robot, you have to have a highly experienced team. So really glad we have Rajani and we have Sanjay here to help out. So I guess without further ado, we'll take any comments from the panel and I'll get started. If we could go to the AP caudal view, I'll get into the LAD with the wire if we can. You can see on the Robo cockpit, you've got a touch screen panel. After they've put a wire with a workhorse wire with a bend and a 2.0 balloon into the guide, they turn it over to me and I push enable all, which gives me control of all three joysticks. One to drive the device, one to drive the guide wire. This one will spin and go backward, forward, and one to drive the guide catheter. It will also spin, go backward, forward. You can disenable each of those individually so that if you grab the wrong handle when you're learning, you don't move anything inappropriately. I'm going to leave them on. So we're all set up. If we could go to an AP caudal view for me. I will take the wire in. I will put rotate on, retract on. This is going to rotate the wire 220 degrees every time I pull backwards. And I think we're probably going to need to advance the guide a little bit to get a little more toward the LAD. And we may need a bigger bend on the wire. Nope, there it goes. Okay, the wire's in the LAD. So now we'll go to the AP cranial view. And we'll take the wire down the LED. That's out a diagonal. Again, rotate on, retract is on. And you can see how the wire just goes down. We're picking up all the side branches. Great example of rotate on, retract's usefulness. Okay, we jumped through a lesion there. You don't have tactile feedback with the robot, so you do have to use your eyes. I'm getting some resistance to the wire I can see as it's kicking out, so I'm going to bring my balloon in just a little bit for better support. And I'm watching the guide. When you move the guide, why is that pressure gone? Good. So We'll take the wire on down now into the distal LAD. You have to realize how the guide moves. You move the guide. You guys, we don't need to test so much. When you move the guide, the entire cassette moves. So you have to remember that. If I'm going to push my guide forward, that's going to push my balloon and my wire forward. And if my wire is in a very distal position, it actually will cause the guide to prolapse out instead of move forward. So I don't need to do that right now. I am going to take this balloon down and see if I can get a pre-dilation done. Okay, and I've got a lot of balloon resistance. Can I see a little more of the guide? Okay, to kick the guide out, I push the balloon forward. So to reseat the guide, I'm going to pull the balloon back, and then I'm going to click the guide forward at the same time. That's going to give me better guide support, and I'm going to do a quick turbo into the lesion. Okay, and I'll take that balloon up there, please. 246, yep, 246. Don't worry. Okay, balloon down. It kind of watermelon seated forward. Okay, so we'll pull the balloon back half a balloon length. That is sucking my guide in. So I'm going to push on the balloon and pull my guide back out a little bit, which should also pull my balloon back a bit. Do the same thing again to get the guide out some more. Now my guide's way out. Let's try to go up there with the balloon. Six, okay, 8 down. Balloon up. 6, 8. Down. With the balloon up, I'm just going to push on the balloon. That's going to kick my guide out a little bit. I'll do one more inflation here. Take that balloon up. 6, 8. That's just nosed into the lesion. Down. Down. Let's try to center up on that lesion. Winged balloon. I've got to push my guide forward, pull my balloon back a bit. Good. So balloon up again. And after this balloon comes down, I think we'll take a test. There's a lesion right there we keep watermelon seating across. I'm going to try to get that centered properly. Down. Let's have a little test here, please.
So Aaron, can you hear us?
Just a minute. I've got to push my balloon to kick my guide out and pull my guide back. Let's go up there, please. Go ahead with that question. I'm sorry.
The question is, so can you hook
8,
everything
10,
up to like
12,
a contrast
down.
assist device and a camera all behind,
Sure.
camera movement all behind the robot?
If you have an assist device, it gets to be an awful lot of stuff. Again, guide sucking in, push on the balloon, pull the guide backwards, then pull the balloon back, and go up there, please. Eight, 10, 12. Down. Okay, I'm going to take the balloon back and take a picture and see what we've got going on here. Okay, you guys ready for a picture? Inject. Good. You think we'll be able to get OCT through? Let's take the winged balloon down. It's still resistant to going, so I'm worried OCT is not going to go, but we can try. Let's just go up there one more time, please. Yeah. 12, 16. And down. Okay. Up again. $16, please. And down. One more time there. 16. If you want to store that for, that's fine. Down. Okay, let's see how the balloon comes out. Same thing. So forward on the balloon, backward on the guide to get the guide out. And then you have to reverse that sometimes when the balloon comes and reverses. Okay, so we don't have any yet. We're coming out. And as soon as they see the markers on the balloon, they yell stop. So now we're just going to do a device exchange, and we're going to try to do OCT just on top of the cassette. This is be a little cumbersome, but let's see if we can get it done. I use Volcano IVUS because you can drive the Volcano IVUS with the robot. You will wind up fracturing the fibers in the IVUS in about 1 out of 10 cases. So you have to be aware of that. You can't drive OCT and you can't drive any of the rotational IVUS devices because it crimps the hypotube, crushes the hypotube. But you can drive some adjunctive devices like Volcano IVUS and lasers. And you can pull the wire back just a little bit, Sanjay. I'm sorry, that's not Sanjay. That's Rajani. You guys want to pull the wire back just a little bit, please? Thank you. If we had Volcano IVUS, you can just insert the Volcano IVUS like you would load a balloon onto the wire and then take it all the way down. I have my technician or my fellow take it down to the ring down position, do the ring down, and then drive it forward and backwards. With the robot, the nice thing is you can click on the millimeter by millimeter button and get a little bit more of a consistently slow pullback. You obviously don't have the resolution that we're going to get here with OCT if it works. Whoops, show the guide. All right. That's not far enough, but do you think that's far enough? Yeah, I think it should go a little further.
I think that's
going
to get your
That's
lesion.
good. That's great. And with OCT, you need a team of 5 people. We're ready. So guys, we'll have to be really careful taking this out. Thank you. I'm going to turn it over to Tejas, and he's going to interpret these images for us. Major question is, do we have circumferential calcium and need to do rotational atherectomy? Or can we proceed with a little more aggressive balloon dilation and go ahead with stenting?
Yeah.
Beautiful. Stay off fluoro for me, would you?
It's a good fibrosis and otherwise normal. This
Not-
is the fibrous area.
And what's the size distally?
Actually,
2.0.
frankly speaking, yeah, 2.
2.0 lumen.
And it's a good landing zone you are going to get for sure. See, this is calcium, but it's patchy. Yeah.
You're going to have to give me permission to put in a 2.5 stent.
So if you see from where, yeah, from that is whirling. Distal looks pretty good. There is some calcium, some fibrosis, and here is the calcium from almost 6 o'clock up to 11 o'clock position, and you see another areas of calcium, particularly regional area, and there. Again, these are the dissections because of balloon, and this is whirling. So I cannot see
That's right.
the proximal good landing zone
Sorry.
in this case. Can we take one more shoot? Pardon? Removed. It's
Yep.
okay, no problem.
Whoa, this is not working.
Aaron, I am able to identify a great distal landing zone for you.
Okay.
Proximal, because of the whirling thing, I'm really not able to see it well.
So you're going to do another run proximally?
Proximal and distal.
Do you want to do another proximal run with the OCT?
I think they have disconnected. Huh? You have to push it in again. But I think you can go in and stent, and then we will do another OCT run.
Let's
and
get
see.
the longest 2.5 NC you've got and dilate that some more because that was pretty hard to get the OCT.
You want to take a 2.5
Yeah.
stent?
No, I want a 2.5 NC balloon.
2.5. If we have 2.5 by 20 NC emerge or NC track.
And
Get
we're
it.
also going to measure for our stent
That's
length,
right,
and we can even compare that to your OCT measurement if you'd like.
This is OCT.
So,
catheter
Aaron,
is a
can
very,
you-
very, very delicate catheter.
Aaron, can you explain? You were saying that we'll do the OCT, and if there was severe calcification required atherectomy, and you were saying this is how I would do the case at home.
Yep.
So what would be the next step? Say, for example, if the OCT showed severe calcium, and if you wanted to do atherectomy, what would be your next steps? Can you walk us through?
We would go to the robot. We would push on the screen the device exchange. We would follow the steps. It's basically disconnecting the connector to the sheath, the guide tract, and then you park the robot clear over on the left radial position, and then take a microcatheter down, exchange your workhorse wire for the rotowire, do your 1.5 or 1.75 atherectomy, and then put your microcatheter back down, put your workhorse wire back down, and reattach the robot. So the point is, you can do hybrid robotic procedures, spend an awful lot of your time in the cockpit. I have a really heavy CTO practice, do about 150 CTOs a year, and initially thought the robot didn't belong in complex procedures like CTO, and then started doing CTOs and realized we would spend 40% of the procedure time in the cockpit, and that's on average 89-minute procedure, which to me adds up a lot over time. So they've loaded up my balloon, my 2520 NC. This guide is... Okay, can I have a test, please? Okay, that's a bit far down. That's a bit far down. I want to dilate from that little tiny diagonal back. So another test, please. Okay, so that's where I want to drop my stent. Go ahead and take it up. I'm also going to push reset and pull back again, and it's going to tell me how long I need the stent, as long as I don't push that balloon forward. So to measure with the device, have we got that up? Take the balloon up. Yep. Just about 12 atmospheres here. Yeah. Yeah, I'm going to come back just a few millimeters and dilate again. So I'm going to try to do this without pushing forward on the balloon so I can wind up with a measurement. Okay, let's go up there and let's go up to 18 atmospheres. I'm going to cine this so we can see it real well.
It looks better. It looks better.
Yeah. I'm happy to go up to 20 if you want. Yeah, let's go to 20 atmospheres. Go high pressure.
The wire is over there making
Yep.
a little
I'm going to actually push forward on the balloon. That's going to kick my guide out a little bit. Okay, and now the wire's just folded over. It's fine. Let's take that down. I'm actually going to remeasure this. Give me a test, please, because it's really sucking the guide in and out.
Yeah.
So this may not measure very accurately in this environment when...
So what you do if this happens? At least I try to put my hand on that turbo button and try to push my balloon in, and then I pull it back.
Yeah, I'm not going to be able to measure accurately with this. Give me another test. Okay, I want to come back a little bit further. This is telling me 29 millimeters. I'm not totally confident because of the way that the guide, when I pull the balloon, the guide is sucking in. So I'm going to measure the old-fashioned way by just sticking my balloon back. Ugh, these winged balloons are not going in. Okay, the winged balloon isn't going to go. That's a bad sign. Do you think we should dilate this proximally with a 3.0?
Okay.
Coming out.
NC emerge 3 by 15.
Yeah, that's fine. But the calcium was not circumferential, right? It was, so it's heavily fibrotic. Here you wonder about angiosculpt or cutting balloons or something else to cut that fibrous tissue because it is highly resistant. This is where it's handy if your cockpit is in the other room and you trust your team really well. You can start your chart work or do something to maximize your efficiency while they're doing balloon exchanges. These guys only take a minute. A new tech will take 2 minutes to do a device exchange until he or she has done 20 or 30.
That this screw is very fast, led by us. I think everybody knows their job.
Now,
And
these guys have more experience than anybody.
We have trained our technicians as well as nurses also, like Harshal, who is assisting, he also knows how to do it, and all others.
And before we got our robot, we started having them do device exchanges on the table for non-robotic cases, and that was really helpful because it's hard to do in the air. So just got to pull the wire back just a bit here, and then we'll go forward on the balloon. Okay, that's that resistant point. Let's go up there, please. Man.
This is a 3 millimeter balloon.
Yeah.
Which inflation looks like.
What pressure are you at?
2.5 max.
How high are you?
How much?
Okay. Just a minute. It hardly moved. All it did was suck my guide in. Okay, go ahead. 16. 18. And down. All right, I'm going to pull the balloon back and take a test. Give me another test here, please. And we got to get here. Take that up, please. 16.
This looks good.
18. Yeah, this
looks
is better.
Good.
You can store that fluoro down. Okay, I think we're better now. Okay, let me see if that balloon will go back. Again, just reseating the guide to get a little more push. That bothers me that these balloons won't go. Okay, I'll take the balloon out. Let's take a picture.
Now you go in, it will go. Once you know, this is what I do many times. It's not going in. I pull my balloon back in the guide, re-wrap it, and then push it.
Okay, let's take a quick picture, make sure all is well. Okay, wow, fibrotic stuff.
There is a good dissection there.
Shall we try one more time to balloon Tejas, or are you happy?
Yeah, go.
Just take it up there, please. 16. I'm just pulling on the balloon.
This looks better.
to seat the guy.
Here it looks better.
Okay. 18 and down. I really don't think this vessel is going to take a bigger balloon. Take that up there,
Okay.
18.
This is sleeping.
Yep.
It slipped.
Yeah, it's too big of a balloon for this size, for this vessel. As the balloon releases, we'll have to come out. All right, let's take a picture. I think it's time to stent. We may need a guideliner to get our stent in. Or do you think we should still dilate that distal lesion? Oh, let me get the wire. Everybody happy?
Which stent size you will use?
I think I'd like to go with at least a 275.
Oh, 275.
Yeah.
For the mid part. This is Indian artery.
From the you think that's too big?
27. If you ask me, I will use a 2.25 stent and inflate it at high pressure. And whatever I want to do, I will do with a quarter size higher balloon inside the stent.
Well, since this is the first Indian artery I've ever stented in India, I will take your advice, because to disagree and then have a perforation would get me thrown off faculty.
and my presumption is even 2.25 will give negative residual. Believe me.
Well, that'll go up to 275 if we need it to. So, okay. I was thinking 275 up to 3.0, but coming out.
Can you answer a couple
stent?
of questions for us?
Yeah.
Can you use a 7 French guide just for education with this setup, or does it have to be a 6 French guide?
It's compatible with 5 through 7.
Yeah.
On label, off label, I do a lot of 8 French CTO work, and it still works with an 8 French guide.
And if you knew you were going to have problems at the baseline, can you preload with a guideliner and still work?
Yeah, there are 3 ports up there. There's a parking port, a balloon port, and a wire port. And the parking port is where you would tuck your guide extension catheter cable.
I think the guide wire is in a very...
It's in a branch. I'll move it when they hook me back up. Thank you.
So what length you want?
Long. Well, actually, if we're going to put a 225 in, I think we can cover it all with one stent. Can we get that up to 3.25?
Yeah.
Okay.
Onyx will go up.
Then longest you got.
That's our 2.25 longest onyx long.
Well, 38 is probably plenty, but
Aaron, do you think that there's a little dissection just near that last diagonal? So
yeah,
I think we probably need to cover that. I mean, angiographically, it
yeah,
looks
I
as
was
though-
going to drop this just beyond that diagonal,
Yeah.
Malcolm. Yeah, there's a haziness on the opposite side of the diagonal that is likely a dissection. So I'm going to drop this one just beyond the diagonal, 3 millimeters or so. If it'll go, we'll see. You know, Tejas's point earlier was on these long lesions. Think about 2 shorter stents. We don't have any side branches to worry about. Let's go 28. Yep, we'll go 28, and then we'll need another bigger one approximately.
38 may give you heartburns.
Yeah.
No pushing it in.
Yep.
But
No, I'm teachable. So we'll put this one beyond the diagonal as far as it goes, and then we'll take another stent. We can actually probably measure with this stent balloon, so we can figure out exactly what we need approximately.
You just ask him, 28 or 38?
That's 28 is fine, but we're going to need another
This
stent.
is 38 he has kept.
Is it open?
It is open. but
Okay, we'll use it. Put it
okay,
in.
We can try and then we'll remove it.
I thought I heard 28. I'm sorry.
No, this is another 28 is available, right?
And we
This
might.
is 34. But this there is a good chance this stent and or zero they can traverse, yeah.
Thank you. Show me the distal wire. I'm going to reposition
Distal wire, please.
that. Oh, you guys did reposition it. Thank you. So coming in, I'm going to go ahead and advance my guide a little bit for some support.
Yes, it has gone. Lovely.
Let's have a test here, please.
Wire.
Yep, I'll fix that. Oh boy, it loves that branch.
Excellent.
Okay.
You want to have a taste?
Yeah, another
Cine.
test. I think I can come back a little bit. Ready?
Yeah.
We'll cine, guys.
Cine.
Well, we can come way back. Again, to
come
do
back.
this,
Yeah,
to
you
do
have
this, I'm
7
gonna have to
millimeter.
pull my guide back a little bit because this is really gonna suck that guide in.
I think.
Did you
maybe.
see that?
Yeah.
So let's do one more test.
Yeah.
Did you see how it jumped backward?
That's right.
The one thing this robot does that your hands don't do is your hands let go of the wire and the balloon, and the tension is immediately released. You need to wait a couple of heartbeats before you drop a stent in an environment like this. So I think we're good. Let's go up there, please. 16. You may get it with this stent.
हलता नहीं हमारा दिलीप भाई 18 20
Yeah, up to 20. We're going to have to post dilate.
Keep it,
Store.
keep it. Record kar. This looks good.
It looks good.
That's what I told. It will give negative residual on both sides. This is Indian artery.
Indian artery. All right. Tell me when we need to come down.
Okay, deflect.
All right. Now this will be the fun
थोड़ा
part.
दुखे तो चला ही ले जाओ. Please. You want to have any comment, Malcolm?
No, stage.
So we're going to try to get this out without sucking the guide in too much. So I've backed my guide out.
तुझे guide catheter
Yep.
बाहर आवे
And remember, as the balloon releases, you'll have to re-advance the guide. I'm pulling the wire back a little bit.
Yeah, that is a good technique. Yeah.
Okay, so now the guide is seated again.
Beautiful.
Okay, let's take a picture.
See what I told?
I don't know. I don't know how you know this stuff.
It
Now-
is negative residual, both sides. 2.25, okay?
So do we post-dilate that middle waist a little bit, or are we good? You
I
tell me.
think even if you like if
It's just
I
gonna
were you
recoil.
at your place and I am working on this patient, at that point I will leave it, or else if at all I want to post dilate, I will decide 20 atmosphere. If it doesn't open, I leave it.
Yeah.
But why can't we do a OCT and see?
Let's do.
So what do people think of? I didn't see this on the pre-film, but just after the
Do what?
septal perforator,
yeah.
you see this late filling. When you replay, you see this?
The septal, that septal.
Yeah, but I didn't see that before, so we've
Yeah.
presumably opened that up, or
If she's
hopefully it's just another septal that we
if
had to see.
she's having pain, yeah, but I think if she's okay, he or she, I don't know if this is a he or she. He. Is he doing okay, Tejas? Is he feeling okay?
There is some discomfort, it's okay. The stretch pain is much more in the population over here.
Yeah.
They complain for sometimes days and many days.
You know, Aaron, you and I were talking about vessel size here, and I thought 2.25 seemed too small. At 2.5, we thought that was a bit of a compromise. But you may or may not have noticed, I've just seen there, the field of view is 15 centimeters.
Yeah.
And I
Yeah.
think that's maybe what's
I
fooling
work
us.
on zero magnification, so
Yeah.
I think that part of it. I'll take that excuse, Malcolm. But
Yep.
the OCT doesn't lie. You know, it was 2.0.
Yeah.
OCT was 2.0 in the distal reference segment. And we
So-
have
so
actually
Aaron,
we have a nice little step down on
Yeah.
on the distal edge of the stent.
Well, just for us, they,
There you go. Wow. I got to see this. I'm the guy that is trying to get 2.25 stents made illegal.
No, not when you come here.
Yeah, in the U.S. you see these in 4.0 vessels all the time.
Yeah. You are going to do it again? Fluoro? 1 minute, wait. Wait. Push karo. Just push it the catheter a little bit. That's right. That's perfect. Central flush. Okay. Fluoro. Inject. No. Guide catheter is out here. You have to adjust the guide catheter.
This is a problem because they're not going to be able to hook it up.
Just pull the stent back and guide will go in.
Yeah, just pull the OCT back a little bit.
OCT, sorry. OCT ખેંચો પાછું.
Test that. There we go.
But you have to go. You have to go little distally. You have to go little distally.
It's
Okay.
just going to kick your guide
Chalo,
out.
there you are. Chalo, go. Fluoro. Inject. There you are going to have a great image.
You haven't interpreted it yet?
Speed reading.
Yeah, that's it.
You can
Very
tell he's
good,
done
very
600.
good,
He's got
yeah.
the interpretation.
See, this is the perfect image.
Yeah.
See, expansion is 69% here. There is a dissection over here in the proximal part.
Yep.
Let us check
That's
it.
pretty long.
Kar chalo. That's a pretty long.
Right.
Otherwise, this is all right.
I'm going to need another one.
MSA is 2.27. Here MSA is 3.15. So,
There's our waist.
so as per the OCT, this thing guideline consensus paper, you go on just dilating, but no, that doesn't happen. These arteries behave differently. Otherwise, I tell you,
pretty good.
despite calcium, it's a pretty round circular lumen. Huh?
Here's our big dissection.
Ah,
That's that's 60 degrees.
I think we need to fix
We
it.
got to stent that.
Yeah,
definitely.
we need to fix it. Now, no problem. Absolutely, now no
Okay,
problem.
you want to measure how long I need it?
I tell you, this is from 45, around 40 up to 52. So 12, 15 millimeter stand should be fine.
Okay.
Let me just check this area, proximal area, the landing zone. That is a good landing zone, no problem.
And what's the diameter? Is that
And
3.0?
the diameter in this region. Diameter in this region. अरे diameter जो है हमारे में. हाँ. कितलो છે? 2.47, 2.5.
2.5. Let's go.
2.5 by 50 onyx. So this modality, you see the angiogram, you don't see dissection in that region.
Looks perfect. Imaging. So I guess the point is, treat the patient the way you would treat the patient. Never change your strategy because of the robot. I worry people
Yes.
would be tempted. Look, we didn't rotablate for very good rationale, not because we didn't want to upset our robotic procedure, but because
Yeah.
we didn't see circumferential or 270 degrees of calcium. But to not rotablate because it doesn't fit into your workflow with a robot is a terrible mistake. And to not image because your imaging devices don't
Yes.
fit with the robot is a big mistake. So do the procedure that's best for the patient. And if it just gets too cumbersome, put the robot away and use it another day.
See this angio. There is some little heaviness now retrospectively you can see in the proximal part.
Thank you.
Ready? Aren't they are quite quick, huh? What do you say?
Yes, indeed. I didn't even have time to.
Another thing is this onyx balloon is more on the compliant side. It expands too much. So you have to be careful.
You like it?
Good. But we have a good landing zone proximally, no problem.
Okay, let's go up there.
12. I think 12 should be good, huh?
Okay, and then we'll go forward just a dot or two
Yeah,
and
that you
post-dilate.
can go as, I think we can dilate the whole artery, no problem.
Okay.
The stented segment rather. Now there is no problem till the distal edge, which we don't touch.
Okay.
It's not going.
No, but I'm going to seat my guide a little bit by pulling on the balloon, pushing on the guide. Turbo a little more. There we go. Let's
This
take
is
that
fine.
up.
Go. 15. This looks great. Perfect.
Okay. Now my wire's going to move forward. My guide's going to suck in, but
But it is
hopefully-
okay now. I think we can leave it at that point.
I'm watching that guide. And then again, as the balloon releases, the guide's got to go back forward. And that takes two hands to do that move. Okay, ready? Final picture.
Aaron, fantastic.
Great.
Fantastic. Congratulations.
Thank you. That was fun. Guides out.
And next lab, we are now shifting to the south lab where Sanjay is already ready. I am scrubbing with him for a very critical right internal carotid stenosis stenting.